Hello, my name is Kelly Close. I'm the founder of the diaTribe Foundation, the editor-in-chief at diaTribe.org. I've had diabetes for nearly 35 years. To our audience, thank you so much for joining us today. And to our esteemed panelists and sponsors, thank you for sharing your insights, your brain power, your resources, your time. We love you.
Hello, my name is Steve Edelman. I'm a professor of medicine in the Division of Endocrinology and Diabetes at the University of California, San Diego and Veteran Affairs Medical Center. I am also the founder and director of Taking Control of Your Diabetes, and I've been living with type 1 diabetes for over 50 years. I am so excited to be leading this event yet again with my good friend and colleague, Kelly Close. So welcome everyone to our 15th annual and second virtual diabetes forum, where we have once again brought together an incredible group of top thinkers and researchers in diabetes to share their expert opinions on groundbreaking research surrounding the current state of diabetes care. Before we bring out our panelists, Kelly and I would like to take just a few moments to tell you just a little more about our organizations.
Thanks, Steve. And thank you, TCOYD, for being a great partner to diaTribe all these years. We started our diabetes forums at ADA back in 2007. diaTribe became a nonprofit in 2013. Our mission is unchanged: to improve the lives of people with diabetes, obesity, and prediabetes, and to advocate for action. So we work to help people be as smart as possible about diabetes through writing about the latest advancements in research to help people live healthier, happier, and more hopeful lives. And we tell a lot of stories about what is going on in the world of diabetes. That helps us support patients and healthcare teams by getting the most helpful and actionable information and insights to our readers. This is just one part of diaTribe's work. This is just one part of diaTribe's work. We also advocate on behalf of people with diabetes through our work on time and range, through our regulatory work, through highlighting and fighting stigma, and through our advocacy efforts in the field at diatribechange.org. We love bringing together and quoting thought leaders like Steve, especially, to make the entire field smarter. For us, it's about making sense of diabetes and giving people the tools and information they need to live their best lives.
Thank you, Kelly. Well, Taking Control of Your Diabetes, or TCOYD, is a not-for-profit organization that is guided by the belief that every person with diabetes has the right to live a healthy, happy, and productive life. Our focus at TCOYD is to educate, motivate, and inspire people with diabetes to take a more active role in their condition by bringing the latest diabetes developments directly to them via educational and especially entertaining virtual webinars, videos, songs, and other digital content with the most up-to-date information presented by the top diabetes experts in the US and Europe, while leading online discussions to share ideas, provide support, and connect the diabetes community worldwide. In addition to that, TCOYD also provides innovative and integrative continuing medical education to healthcare professionals caring for people with diabetes. Kelly?
Right on. So before we bring out our superstar panelists, we're going to share now some brief videos that highlight a little bit more about the work that diaTribe and TCOYD do every day. Let's roll.
Diabetes is an important public health epidemic because it affects hundreds of millions of people around the world.
Through our education efforts, we are working with patients at an individual level and really providing people with actionable information to make them smarter about the condition.
So just 2 weeks ago, we reached 200,000 subscribers to our newsletter. It's been, very quick growth.
Working at Close Concerns, it's really cool that we are able to make an online resource that encompasses all of the newest coverage in diabetes. I came from a science background in college. Projects that I'm really enjoying working on at Close Concerns is a sort of stem cell research project.
So I work on the DQ&A international team, and I am really excited because we're about to launch our first survey in Italy.
One thing I didn't expect is how big the diabetes stakeholder landscape is.
I didn't expect to have so much influence over the direction of the organization. I honestly didn't expect how much responsibility and trust you're given so quickly, which is really unique for a first year out of college position.
Right when I started, I hit the ground running. We're really making real world impact from day one.
The program really encourages you to pursue your future degree or your future career and really has a ton of resources in place.
Everybody is a learner, everybody is continuously kind of striving to be better at what they're doing.
Since 1995, TCOYD's mission has been to bring the latest and most up-to-date diabetes education directly to the people who need it the most. And that's the people living with type 1 or type 2 diabetes and their loved ones.
With nearly 500 million people living with diabetes worldwide, including myself, most primary care providers find it difficult to keep up to date with the latest advancements in diabetes care. So TCOYD works hard every day to be the go-to resource for anyone in the diabetes community who wants to take control of their diabetes.
Whether you've had diabetes for 5 months or 50 years, TCOYD has so many resources, educational conferences, engaging and entertaining webinars, interactive health fairs, articles written by diabetes experts, even funny original songs and skits, plus thousands of hours of educational videos in our video vault. And it's all available for free.
So TCOYD is known for our funny and entertaining videos and songs that we produce. And in addition to just being naturally hilarious, we do this for 2 reasons. One, research actually tells us that humor leads to information retention. And 2, living with diabetes is hard. And sometimes we just have to laugh at the crazy things we go through every single day. Plus, I get to wear crazy wigs and pretend to be a rock star, which is pretty awesome.
I've always said that if you have diabetes, you have to be your own best advocate and learn as much about it as you possibly can. And if you do that, you can live a happy, healthy, and productive life with diabetes.
Of course, we couldn't do any of this work without the support from our generous sponsors who are not only making this panel discussion possible, but who also engage in so many other ways with what TCOYD and diaTribe do every day.
From all of us at TCOYD and diaTribe and the people we serve, we sincerely thank you for your continued support that allows us to reach people with diabetes and healthcare professionals all around the world. If you'd like to support our work that we do collectively, we'd ask you to consider making a donation at the URL you will see on the bottom of the screen.
Let's start with a huge thank you to our most generous best-in-class sponsors, AstraZeneca, Dexcom, and OneDrop, as well as first-in-class sponsors, Lilly and Sanofi.
And big appreciation to sustaining sponsors, Abbott, Adocia, Ascensia, Bayer, BD, Bigfoot, Dompe, Genentech, Medtronic, Prociento, Prevention Bio, Tandem, and Zealand Pharma.
And thanks to our supporting sponsors, the BI Lilly Alliance, Secure, Insulet, and Novo Nordisk. We couldn't do this without you. Now let's bring out our extraordinary panelists. First off, we have one of the world's leading voices in basic and clinical research in diabetes, Dr. Daniel Drucker. That's at Daniel J. Drucker on Twitter, where many of us follow him closely. Dan is most well known for his bench and clinical research at the Drucker Lab in Toronto.
Next, we have Professor Rury Holman calling us in from the UK, the founder and emeritus director of the University of Oxford's renowned Diabetes Trial Unit. He helped invent the UK-PDS risk engine and the UK-PDS outcomes model. And we'll be very interested to hear what he has to say tonight about implications of the pandemic, as well as for his latest thinking on the cardiovascular outcome trials. Welcome, Rury.
Yeah, and we're so very lucky to also have with us tonight past ADA president, Dr. Sam Dagogo-Jack, who heads the University of Tennessee's diabetes unit. Dr. Dagogo-Jack is known for his work on prevention, specifically on how genetic and environmental factors interact in the prediction and prevention of prediabetes and type 2 diabetes.
And we have Dr. Jeremy Pettus. He's an associate professor of medicine at University of California, San Diego, and director of the Type 1 track and CME department at TCOYD. He is particularly well known for his being patient-centric, as well as for his opinions on the T1D cure research and his leading research on type 1 adjunctive therapies. Jeremy and I have been friends and colleagues now for over a decade, and he is truly an amazing individual who will be a diabetes leader for many years to come.
Davida Kruger is a highly regarded certified nurse practitioner, clinical trial leader at the Henry Ford Health Center in Detroit. She's very well known for her insights on the intersections in diabetes, especially drug delivery and technology, and how to drive outcomes in GLP-1, SGLT2s, and the closed loop. Davida got one of the ADA's biggest honors a couple of years ago when she was named Educator of the Year. How incredible to see everyone here tonight. Hello, and welcome to our distinguished panelists. Steve, take it away with our first question.
Okay, well, thank everyone again. I'm going to start off with Sam. And I don't think there's any more an appropriate question to open the forum to talk about the effects of COVID-19 on diabetes. You know, can you open up the discussion, you know, how you relate the pathologic defects, let's just stick with type 2 diabetes for now, and how they relate to the clinical course of an individual who gets COVID.
Sure, Steve. Welcome, everybody. It's really tragic that very soon into the pandemic, data from China began to flag diabetes as a susceptibility condition for increased COVID infection. Subsequently, we learned that diabetes also predicts worse outcomes, including death. And then data from Europe, particularly initially Italy, and then across Europe, began to support the early China data. So we now know that diabetes not only is a risk factor for contracting COVID, but it does predict worse clinical outcomes. In terms of pathophysiology, we really do not have very final data on it, but we have inferences. There are data showing that the receptor used by the virus to enter cells might be upregulated, the H2 receptor, in the condition of diabetes. There is also animal data that some of the proteases that enable the virus to shed the spike protein and penetrate cells might be upregulated. One particular protease is called furin in people with diabetes. And then the cytokine storm, the inflammation that has been much talked about, is also kind of a connection to diabetes, knowing that diabetes is a pro-inflammatory condition. So many factors, including but not limited to observations that the virus itself can enter the beta cells in the islets of Langerhans and disrupt cellular vitality and consequently insulin secretion. So it's sad but true that diabetes predicts worse outcomes in COVID. What about the blood glucose? You did mention blood glucose. Yes, it's not binary diabetes or no diabetes, COVID or no COVID. Actually, the glucose seems to be driving some of the pathological processes, which is good because it's an actionable observation. And there is now important data that glycemic control in the setting of all of the drama, intubation, ICU, but if you do not ignore glycemic control, you are serving your patients well, and you can help decrease the clinical outcomes, the adverse outcomes from COVID infection.
Thanks, Sam. Hey, Jeremy, could you give the folks a one-liner on your take with COVID and type 1? Because I know the story has changed from being less of a risk to just as much with type 2s.
Yeah, I'd say the bottom line is that unfortunately we found out that type 1s are just, equally at a high risk as people with type 2 diabetes. When the whole pandemic first started, we were thinking, Steve and I, like, gosh, hopefully type 1s are more like non-diabetics than type 2s, and hopefully we're okay. And we basically did a comparative analysis of people getting with type 1, type 2 versus healthy controls in a large data set. and found that type 1s are much more like type 2s than non-diabetics. So the ultimate message became, if you have diabetes, you are at higher risk. And that's been the story, unfortunately.
Well, we're all blood brothers, as I say. Okay, last part. Go ahead, Kelly.
And sisters, but yeah, go ahead.
Yeah, you're right. Okay, Davida, last part to this question, then we're going to get to the next question. You're in clinic a lot, you do a lot of clinical research. How do you think, this has affected the outpatient therapy of people with diabetes? And, I know we've had televisits, video visits, and now that COVID is hopefully continues to get better, what do you see happening in the future with care of people with diabetes?
Well, we flipped our entire clinic in March 2020 to virtual. We still went to the clinic, but we flipped everybody virtual, and we learned a lot. We learned that people weren't connected in the cloud, and we learned a lot of things that we had to change. But I'm not seeing people coming back that quickly. I think that what we've tried to say is, could we see you at least once a year? But for people who, especially people with, that we're seeing 4 or 5 times a year, if we can do it through telemedicine, we can access their data, we can get their lab data. It really fits into their life, into a nice lifestyle. They don't have to leave their office if they finally got back to work, or if they don't have childcare, or a host of other things, or they can go to visits that they can't do virtually. So I think this is the wave of the future. We'll figure out best practices, and I'm sure we're not there yet, but I don't think telemedicine is going away, and I don't think that's a bad thing.
Yeah, and I'll just say one quick thing is that we all have patients who are just doing extremely well, and all you talk about is their favorite Peloton instructor when they come in. And then there are patients that they're not going to get better unless they get in your office.
Correct.
Best practice.
And I think also when the patient identifies themselves and saying, I do better if I come face to face versus, I'm going to do another video visit and I'll see you in 6 months.
Yep. Dan, did you want to say something?
Yeah, so I think we all recognize that blood glucose and lipids and numbers can be beautifully discussed and adjusted in the clinic. But, I don't want to pretend that I'm a big William Osler fan for many reasons, but you really need to examine the patient. The programs for virtual foot care are not great. It's very hard to assess vibration and proprioception and nerve damage online. It's very difficult to feel someone's liver edge or for splenomegaly online. And my concern is that while we have clear benefits for virtual medicine and telemedicine, we are going to miss many things that require a physical exam. There's a reason why when you go to medical school, you need to learn to examine patients. And I think we risk impairing some of our diagnostic acumen if we, at least as you say, maybe once a year or twice a year, bring them in.
But I think those are the things that we have to make sure as we move forward that we put into the curriculum and we don't miss. And we also work with our primary care colleagues who may see them as well. And so the right and left hand work together. You're absolutely right. They need to come in at least once a year, if not more often. And we need to work with our other colleagues to get all of that done. Agree.
Yeah, we need more physical. We need more physical exams before COVID even. Okay, Kelly.
And all these patients out there, like me, I've had diabetes almost 35 years now. I'm listening. I'm loving that. By the way, William Osler died December 29th, 1919. He was 70 years old. Less than a year later, Frederick Grant Banting began the research project at the famed University of Toronto to find a treatment for diabetes. So just get a little translation in there. But Jeremy, I want to go back to you about type 1. Can you talk about adjunctive therapies for type 1? A lot has progressed since a year ago. As a clinician, as a person with diabetes, as a rising star researcher, tell us about the area. GRAs this, especially just what are you thinking about in glucose and potential cardiovascular benefits for type 1?
Yeah, so this is an area that I've been really excited about for a long time. And we actually did a consensus statement with the ADA and EASD on adjunctive therapies as an area that I had to do in 5 minutes. So be sure to watch that and kind of all the pluses and minuses and the space in general. But for glucagon receptor antagonists, that's something that I'm really excited about. I mean, there's so much to be excited about in type 1 diabetes right now. And we just finished a phase 2 trial in 150 type 1s and found that a once a week injection.
Oh, okay. we lost Jeremy. Let's continue.
I think Rury wanted to say something earlier on.
Yeah, Rury, please say something.
Yeah, I was just going to follow up on Dan's comment that face-to-face and physical examination remain essential. But what we've learned from this enforced pandemic is a different way of working. And what I'd like to see is perhaps more frequent but short, virtual sessions with patients, so that we can fine-tune their medication, support them perhaps mentally and in their daily life better than we do with what in the UK are quite spaced out consultations.
Yeah, Kelly, why don't we go to Davida next, and then when Jeremy pays his electric bill and comes back, he can talk about GRAs, and I'm sure once Jeremy finishes, I'm sure Dan wants to comment on GRAs as well.
Yeah, I'll take it down. I'll let him build it up, and I'll take it down. So,
yeah, thank you.
Okay, Davida, we're going to go back to talk about another hormone that we haven't heard as much about in a while, but you have so much experience with pramlintide, or what we know as Simlin. And can you talk about the resurgence of this and the formulations about?
Yeah, it's actually pretty cool. So yes, I did clinical research back in the day when it first came to market, and it was phenomenal. We weren't quite sure what we were working with, and it took forever to come to market. But what we know is that the beta cell has two hormones, insulin and pramlintide, and when you lose one, you lose the other. And we were replacing it, and I still have probably a dozen patients that take Simlin, which is the marketable name of it, by injection, and they're very satisfied with it. But it is at least 3 extra injections a day. In some people, there were a fair amount of nausea, but when we replace that hormone, we get rid of that postprandial ride, we get rid of the extra glucagon, and most importantly, we get a sense of fullness, a sense of satiety, which so many of our patients truly, truly like. The problem is the nausea for many patients and the multiple daily injections plus either pump or Simlin. So in walks the combination, and it's really been the data has been very cool using analog insulin, and it's a combo, and it wasn't easy because of the type of molecules they are, but being able to give them in the same, injection you would say, but it's the same molecule. And there's substantially less side effects with great response with the analog insulin for postprandial control and for the satiety. They've done it with regular, but it wasn't as satisfying, the results. But the analog insulins look very promising. And I'm very excited, having been a fan of it since day one and having so many patients that are still using it. So stay tuned, but I think this is going to be great too.
Yeah. I agree with you. All right, Jeremy's back.
Sorry, my Zoom account kicked me out there, of course, right when I'm talking. But
Jeremy,
pay the bill. Pay the bills, Jeremy.
Pick it up where you left off, Jeremy.
So the glucagon receptor antagonist, there's a lot to be excited about in type 1 diabetes. This is probably the thing I'm the most excited about. A compound that I've been working with for probably the last 8 years or so. And the whole idea is that type 1s are, we have exaggerated glucagon responses at times, and that potentially blocking glucagon could improve glucose control, et cetera. So we just finished a large phase 2 study. It was 150 subjects with type 1 diabetes, so very big phase 1 study. This is a monoclonal antibody. It's a once-a-week injection, and we did it for 12 weeks in these patients, and actually found that with therapy, on average, people lowered their A1C by about 0.6%, which in the type 1 world is fairly dramatic, especially when we were talking about 0.2, 0.3% and SGLT2s. And then we looked at patients that came in with an A1C over 7.5% at baseline, so slightly higher A1C. And those folks lower their A1C by a full percentage point. So this is, has very profound reductions in glucose. We had CGM data that showed that people had increases in time and range, and importantly, no increases in hypoglycemia, which is obviously something that you worry about. We can talk more about other kind of safety elements that we looked at and things like that. What I'm also really interested in is that our lab did an independent study where we put people on this compound and took them off their insulin pumps to see how easily they can make ketones when on, there's no air quotes there, how quickly they can make ketones when they're on this compound. And basically found that when you are on a glucagon receptor antagonist, it's very hard to make ketones. And hopefully this would make patients less prone to DKA, which again has been a problem with not only SGLT2s, but some of the GLP-1, early data. So big picture, I am excited about it because it's potentially a once-a-week injection to improve glycemic control, to maybe offset the risk of DKA. Some things to be, looking at is that these compounds have been looked at for type 2s and had increases in transaminase levels, in particularly hepatic fat. So we did see mild increases in AST and ALT, but no increases in hepatic fat when we did MRIs. And then the last thing is that we did blood pressure monitoring and found that this increased systolic and diastolic blood pressure slightly. So these are things that are going to need to be evaluated. They already have a phase 3 program kind of mapped out to start hopefully in the next year. So it's just really exciting to be talking about a phase 3 study for an adjunctive therapy in type 1 diabetes. I'm a huge believer in this space. I think there's a large opportunity for using other medications, or at least addressing other pathways in type 1 diabetes like we do in type 2. And like I was saying, for my ADA EASD consensus thing, that, there is a need to discuss adjunctive therapies, where they fit, where they don't fit. It was interesting doing that with my European colleagues because they use SGLT2s, we don't, we have Simulin, they don't. And, where we kind of all come together on these things was a lot of fun. So I'm curious what Dan has to say as the glucagon response.
Yeah, so I think these are powerful medicines. And we saw in the type 2 programs that, Merck's GRA thrashed metformin in head-to-head studies. It wasn't even close. So there's no question about the power and efficacy. The problem, as you alluded to already, is, the risk benefit is like a threading of a needle. And when you get into 1,000 or 2,000 people, I think it'll be very difficult to avoid these adverse events, which, as you know, include dyslipidemia. The liver is not happy when it doesn't have glucagon action. Amino acid and lipid metabolism are messed up. Blood pressure is increased. Pancreatic alpha cells increase even in non-human primates. So I think that it will be a very difficult de-risking of this mechanism because of these on-target liabilities, and we'll just have to see.
We're going to be listening closely for
Okay.
what you guys say. I think we're going to switch to a related topic. There's been such an explosion of data here at the ADA scientific sessions on SGLT2s and GLP-1 and type 2. In fact, there's kind of been such demand that people with diabetes are trying to get their hands on them wherever they can, right? Take a look.
Hey, man, I hear you got some good stuff.
Yo, you're not with the FDA, are you?
No way.
All right. What you need? I got type 1, I got type 2.
Type 2.
All right. What you want? I got GLP-1s, I got SGLT2s, I got basal, I got short-acting. What you need?
You know what? I don't really know.
Oh, man, I got you. These new GLP-1s, man, you take this injection, helps your diabetes, protects your heart. You can even lose some weight. I mean, damn!
Whoa. Tell me more about the
SGLT2, bro. These are rad little pills. You take this once a day, you'll be peeing that sugar out in no time, bro.
Wow. Do they also protect your heart?
Do they protect your heart? For real, they protect your heart and your kidneys, and you can even lower your blood pressure, bro.
Whoa. What else you got?
What else I got? That ain't enough? Well, don't worry, man. I got the new rapid-acting insulins. Lunjet, Fiasp, Afrezza. I got these long-acting basal insulins. Just one shot a day, bro. One shot a day.
I can't believe how many options there are for people with type 2 diabetes.
Legit. So what's it going to be? Come on.
I'm going for the oral SGLT2.
Cool. So just hit me up with your insurance card.
Insurance card?
Yeah, bro, I got to run your copay.
What? No way. I'm out of here.
Well, good luck getting your prescription filled at CVS then.
So as you can see, these new meds are really in demand.
Yep. Steve, I'm definitely still going to need to see your insurance card, though, to get some of those.
Thank you. Okay, Kelly, keep going.
Yeah, tell me, Rury, everyone, what other changes would you like to see on the ADA standards of care as we think about the use of these medicines, and specifically about CVOTs, diabetic kidney disease, treatment algorithm updates?
Sure, Kelly. So the most recent iteration of the guidelines is probably one of the most impactful yet. As a clinical trialist, I am delighted that we now have the evidence base to actually recommend these therapies. And that's where we can now drill down. So for atherosclerotic cardiovascular disease, particularly with the GLP-1 RAs, the diabetic kidney disease and heart failure with the SGLT2 inhibitors. These are really powerful tools. I think where we just need to be a bit cautious is they do need to be used in the appropriate populations. We've just been talking about de-risking things. And increasingly, particularly with screening, we're now seeing many more patients identified with diabetes much earlier in the disease course. They don't have renal disease. They don't even have cardiovascular disease yet. And then the question is, when do you want to start these? And I think the next big thing will be much better risk calculators. There's a nice new one, SCORE2, just come out in the European Heart Journal for Europe. I'm sure we can extend it to America, in which they have now calibrated this on a country-by-country basis. And so if you want to tailor treatment to the people who most need it, then some sort of calculation for their renal risk and their cardiovascular risk would help guide the clinicians and the patients in the best way forward.
Really cool. And so that's something that all of us people with diabetes out here, that's something we can ask our doctors about. Dan, tell us about your thoughts on high dose GLP-1.
Well, I was going to be inflammatory, so I wouldn't disappoint anyone on the panel. But, you know, the take-up and utilization of these new medicines has been very slow and disappointing. And so, Rury, let's leap ahead now. We're in the clinic. Forget about risk calculators and cardiovascular and renal disease. I'm just going to give the person in front of me a choice. You can go on metformin, you can get a 1.3% reduction, 1.5%, maybe you'll lose 1 kilogram, or you can go on semaglutide, you'll probably lose 5 or 6 kilograms on average and maybe have a 1.5 to 1.8% A1C reduction, or probably in 12 months you can go on tirzepatide and you can lose 20 pounds and have your A1C normalized. I think this is going to blow open the way that we treat diabetes, and we're going to have to abandon our conservative historical approach and acknowledge the power of new medicines.
Dan, I think you're perfectly right. The issue is the person you're describing is established diabetes, overweight, high A1C. That's not the same as a newly diagnosed or a pre-diabetic patient who is not overweight. And so there has to be some rationale for who you give when. What you did put your finger on quite correctly, and the thing that has always been a problem, when we get trial data that is positive and in fact irrefutable, it still doesn't translate into clinical practice, sometimes for years. So I totally agree with you that we need to get these drugs into more people earlier. Just, you know, do it in a way that is cognizant of the risks and the adverse effects.
So Sam next, and then Davida. Thoughts on this?
Right. So quickly, both views can be reconciled. We obviously cannot put it in the water. We are diagnosing close to 1.8 million new people with diabetes in the US each year. If you look at their glycemic spread, they are not all at A1C of 8, 9, or 10%. Some do not need the 2.5 percentage point drop that tirzepatide would give. So we need to use judgment call. And there are some people for whom diet and exercise will maintain current glycemia for some time. And others will need us to go nuclear and bring in the biggest stick to hit the glycemia.
You know, go ahead, Davida. I have a quick comment.
I was just going to say I'm somewhere between Dan and Sam, and maybe Rury, in that I actually lean more to Dan in that I think all of these patients are going to have cardiovascular disease, and we should be preventive instead of waiting till it happens. You know, I think most of us don't see the people with diet and exercise. We see them farther along anyway. And I think that that's not, they're not successful long-term, where if I can give them something once a week, once a day, that provides satiety, weight reduction, lowering A1C to the max that they need, and can give them a cardiovascular benefit as soon as I get to know them, so that if I don't see them in a year, they're still getting the benefit. You know, I worry about them falling out of the system, not being cared for, perhaps in people that are not as knowledgeable about diabetes. And then, of course, in the United States, I worry about not being able to get reimbursed for any of this, which is humongous and another whole story.
Yeah, and I'll just add that one thing that diaTribe does, and TCOYD, we work on the other end. You know, educating doctors is one thing, and changing their prescribing habits is really tough. but getting the patients knowledgeable and then having them create a dialogue with their caregiver and asking for it. And then, Dan, it comes down to access. In Canada, you guys have everything, but in the rest of the world, it may not be that way. No, I'm just kidding. I'm also agree with everyone on the panel that it's the right situation, but I think things are moving faster than they did 20 years ago. So at least we're going a little bit faster than we used to, and the choices are awesome.
And I think
we need to, I think we are now in the position where we can act more like oncologists and less like endocrinologists. We have a serious disease. It causes tremendous morbidity and mortality. We now have very powerful tools that will put this disease into remission, and in some people prevent it from progressing, and we will have diabetes-free, complications-free existence if we use our powerful tools. We did not have these a few years ago. Access is a problem, education is a problem, but we need to be more aggressive with a different mindset on how we're going to use these new tools effectively.
Yeah, and I just say one more thing. Maybe Rury or Sam or Dan can comment on this, or Davida. We now have suggestions for people who are at risk for congestive heart failure, chronic kidney disease, and that is incredible based on these CVOT and renal trials now. So those are tremendous advances we have. And now I feel like I'm a colleague of the cardiologist and the nephrologist because we're all starting these drugs. They drive nicer cars than us endos do, but other than that, we're friends.
But just to come back to what Sam said, those drugs should be in the water for people with type 2 diabetes. The SGLT2 inhibitors are not that expensive. They have tremendous benefits, and we should be utilizing those drugs to a much greater extent and not just waiting till the EGFR drops or we have a little reduction in ejection fraction.
So I would agree with Dan to a point. So the data on heart failure prevention and on kidney protection are now so solid that diabetes is not even required. So the DAPA-HF and the CKD studies show that you don't need to have diabetes for your kidneys to be protected. So using these agents to protect kidneys and heart failure is without question a very judicious and timely intervention. The atherosclerotic heart disease, the MACE events though, when you look at the meta-analysis and the studies reported to date, we cannot quite make a strong argument for primary prevention. So I think therein lies the need for multi-risk factor containment, like the steno-2 type intervention, rather than just relying upon a diabetes drug to lock in atherosclerotic benefits. Congestive heart failure, kidney, I'm on board, but physicians need to do more with regard to the MIs and the other components, which seem not to be primarily preventable with SGLT2 or GLP-1 arrays, as we know the data currently.
What are the two most underdiagnosed serious issues that we have? Renal disease and congestive heart failure. So it's amazing what this one class of agents can really do.
Right.
Okay, well, let's switch topics again and talk about what's happening in the world of hybrid closed loop systems and the artificial pancreas. As many great things are happening in type 2 diabetes, they're also happening in type 1. We know that this is something a lot of people are working on. And as a matter of fact, Jeremy and I have been working on our own system as well. Take a look.
Steve, how's it going, man?
Hey, Jeremy, what's going on?
I'm just here picking up the new garden gloves that just dropped today, so I had to be first in line for these, obviously. But what are you working on? Some kind of home improvement?
No way, man. I'm building my own do-it-yourself artificial pancreas. I'm sick of waiting for it.
Well, Steve, you're an endocrinologist. You know what a DIY pancreas is, right?
Listen, Jeremy, I've been thinking about this for a long time. I got it all figured out. Really strong tubing so there's no kinking. I got a plunger in case there's any clogging, and a crowbar. It's made of metal, improves the signal, no dropping out. Think about it, man. Excuse me.
You might be onto something. Oh, Steve, check it out. Gorilla Glue.
Awesome. This thing's never gonna fall off. Hey, what's the beer for?
Oh, that's just for me to drink later. But you know, not that we need to, but maybe we should check out Dr. Lai's session on DIY artificial pancreas systems. He's coming to us all the way from Stanford, California.
Cool. We could show him ours.
Totally. Let's go.
So Davida, you know, other than the progress that Jeremy and I have been making at the hardware store, will you speak about some of the clinical research and advances in hybrid closed loop system? You know, will these devices be on the market soon, the advanced, the newer ones? And how are they making an impact in clinic, time and range, other metrics?
Well, first of all, I always tell my patients, it's never a good time to have diabetes, but this is about the best. When I think of what it looked like 39 years ago when I first started in diabetes, you know, the humongous pumps, we had to dilute out the insulin, we had to plug patients in at night to charge them the pump. And I think of what we have today, it just is mind-blowing. So we have a couple of pumps that have been on the market for a while that are some of our hybrids, and they do really very well with protecting our patients from hyperglycemia and hypoglycemia, working with CGM, which is phenomenal, and making the job easier for the patient, and also closing that loop between the healthcare provider and the patient, because they really do drive that more if the patient can drive it more with that data. And then we have a couple of new kids on the block that I think by the end of the year, like the Omnipod 5, which will be out most likely by the end of the year for those individuals who would prefer a pod situation, who do not want cord. And at the ATD meeting that just occurred showed some phenomenal data. And, you know, here's the thing is, I think that if you pick a pump and you like the features of the pump, it's all going to get you to treatment goal with education and all the other stuff. These are facts. If you put the CGM on, you do a hybrid, you get the education, you have the clinical support, you will find your life in a better situation. And so all of the research, I can go into minute details of each of the pumps, but the fact is patients should be on a hybrid closed loop until we have a closed loop. They should be connected up to CGM, and they should pick something that's really great for their life. The other comment I will make is that most individuals have to wear an insulin pump for 4 to 5 years. 4 years for warranty, 1 more year before their insurance company will buy them a new pump. And so what I tell my patients, if there's nothing truly wrong with your pump, wait, even if you're out of warranty. We're going to see a huge explosion between now and the next 2 years, 3 years. And I want my patients to be able to get the newest, the best, whatever they want in life. And so right now, unless you're going to move into, say, from what they're doing right now, if they're not in a hybrid and they want to move up from, say, a regular Omnipod to an Omnipod 5, or, you know, if you're on, say, a T-Slim and you have Control IQ, that's a phenomenal pump. Is there really a lot of difference in the new version that's going to come out? Maybe not. Really evaluate this with your patients so that they're not stuck in a warranty. If we have, like what I know Jeremy and you and I are doing the work for Beta Bionics. I mean, and that should be out next year. And I want my patients to be able to have choices.
Yeah. Well, Jeremy, can I say one thing before you go on? We should do a shout out to Bigfoot and the approval of the Unity,
yes,
which is a smart pen communicating with a CGM and with input from the patient's healthcare professional, is kind of a MDI hybrid closed loop system. So that'll be quite interesting and see how that plays out in the community. Okay,
well,
Jeremy.
Let me just tag into that, Jeremy. I apologize, but I want people to know too, the beautiful thing about Bigfoot is that they get to use their insulin pens that they're used to instead of having to move to cartridges, which I think is a big plus for a lot of our patients as well. I'm sorry, Jeremy, the floor is yours.
Oh, I was just going to say, you know, I went on Control IQ 2020. That came out 2020. One good thing that happened in 2020. And that really was eye-opening for me and my patients that, you know, every day waking up with a good blood sugar, not because I'm smart or I'm an endocrinologist. I have this system that's giving me more or less insulin so that I wake up with a good number. And now with Omnipod getting, you know, their system on board, we're suddenly in a place that we basically were 5 years ago with the same companies, the same pumps, except now they're all going to have hybrid closed loop options. And, you know, I do think with what I've learned with working with Beta Bionics and these different systems is they obviously have their benefits, but they're still pumps. There's still a lot of training and a lot of education. And, you know, Steve, we made that video a while ago about, are these systems going to put us out of business, you know, kind of jokingly? Yeah. And the answer is no. I mean, they still require a lot of effort. Nobody wants to wear these pumps. So there's still room for adjunctive therapies or whatever it might be. And it makes me think that, glucose control in type 1 diabetes, it is a solvable problem. I mean, eventually we will be to a place that people can go on these systems and have it automated. And then I think that will bring around a shift to remembering that people with type 1 diabetes, they die of cardiovascular disease, that these are things that are not controlled by glucose, and how we need to be remembering that and thinking of other ways to, in addition to glucose, to help our type 1s, live long and healthy lives. So big, long way of saying these devices are amazing and they keep getting better. And there's just so much to talk about with type 1.
And I'm just going to jump in and ask Davida, what do we think about for, the standards of care though in type 2? We've seen what happens when time and range can go up exponentially from people on insulin. Maybe it's smart pens, maybe it's pumps. It was early data in Horizon in the type 2s. But what do you think about type 2s and standard of care related to CGM? Is that insulin only? Does it have to be?
Why shouldn't they be on insulin pumps? That's absolutely should have the opportunity to be. And we have a ton of patients on insulin pumps, and you'll see some editorials and articles coming out real soon from the diabetes journals that we just published, and talking about changing the standards for Medicare so we can get rid of that C-peptide issue, so that it makes it easier for people who have Medicare, and that will trickle down. But people who have type 2 diabetes are on multiple daily injections. Why shouldn't they be on insulin pumps?
Yeah.
And also, but the standard of care, how do you think about standard of care for CGM for people with type 2 through the course of?
Well, I believe CGM is a right. And that everybody, it's not a privilege, it's a right. And I don't know how, 39 years ago when I came into diabetes, we held blood glucose monitoring close to our chest, and we said, maybe you get it, maybe you get it, maybe you get it. And we didn't give it to enough people because we didn't know enough about it. We didn't have the availability, we didn't have the insurance coverage, and it was way expensive. And we can't do that with CGM. If you have diabetes, it'll help you manage and learn your care. Now, we could argue forward till the cows come home. If you're only on oral medications and GLP-1s, do you need CGM? Of course you need CGM. And the reason you need it is because it's lifestyle changes, as Sam has pointed out, that people with physical activity and nutrition make changes in their life. And if they can get the feedback, they make bigger changes in their life. And more importantly, they own their diabetes. And I always tell my patients, I do not go home with you at night. That is a really good thing for you and a really good thing for me. So I think that standard has to change as well. Insurance has to cover it, and it should be a right, not a privilege, and everybody should be afforded it. And when the cost comes down, so it equals equals finger sticks, that's probably when the huge turnover will be.
And so a right, not a privilege. Do you also feel the same way about glucagon? And Steve, we'd love your opinion on this as well, and anyone who wants to talk about these new glucagon preparations.
Well, I'll open the discussion, but I do think Davida should run for president of the United States for that speech. And I also want to hear a little bit about what Dan thinks about CGM for type 2s, because I want him to say something positive, on the forum.
Yeah, no, I think what the problem that I have is that it just broadly becomes everybody with type 2 should have CGM, and then I think the payers and the insurance companies might start to say, well, wait a sec. So I agree, if you're on insulin 100%, every now and then to learn more about your diet and exercise and how that translates into your glycemic excursions 100%. But I think we need to be a bit thoughtful rather than saying CGM for everyone with type 2. I don't think we would see a big benefit if we did that.
Yeah, well, that's $500 billion a year. So I don't think that we were implying that, but just are there specific points?
I can put my hopes out there.
Rury,
I can put my hopes and dreams out there, can I?
That's a lot of fancy cars for endocrinologists, Steve. So I think we need to be thoughtful.
So for people with type 2 diabetes, regular CGM is not essential, but intermittent, particularly those on oral therapy, is very helpful. Allows them to do a reality check on their lifestyle, their medication, and what they're eating. But here in the UK, where medication is free at the point of delivery, we now have flash monitoring for patients with type 2 diabetes on insulin. And the reason is it's actually cheaper than the finger prick sticks. And of course, it's that much more helpful. So I think that's a right for them. Anybody on multiple daily insulin should have that monitoring, and preferably a hybrid closed loop system. But for the vast majority of people with type 2 diabetes, I think just intermittent checks is a much kinder way of doing it than the finger pricks.
Mm-hmm.
Well, we should go on, Davida.
Yeah, we're going to just move on and just ask about glucagon here briefly. Like, is there anyone who shouldn't have glucagon? Talk about that, and especially
Jeremy, go ahead.
Yeah, I mean, I think just real quick, the background and having these new formulations, it really is a big breakthrough. I mean, we've had that Lilly glucagon kit forever, which God bless it, but it's so complicated to use. And if you have a loved one who's having a seizure on the ground and you have to take out this vial and inject this other thing and mix it and draw it back up and inject it, it's hard enough for a healthcare provider. But again, if you don't have any healthcare experience and your husband or wife is having a seizure, it's just awful. You know, Steve and I did another video on glucagon, and we brought our production manager, Eric, on to try to interpret like the instructions on the Lilly kit, which is, and you just can't do it in a low stress environment, let alone when someone's, having a seizure. So having now, pre-mixed injectable glucagon or intranasal, that's so helpful for a couple reasons. One, it's just a more practical way to save somebody's life if they're having a severe hypoglycemic episode. There's other two things that we can do with glucagon: put it in pumps, put it in formulations, all those kinds of things. But then the last one is, I think it's just starting to create a re-awareness around severe hypoglycemia, how common it is, not just in type 1s, but type 2s on insulin, ways to prevent it, all that, all that stuff that actually comes when you have new therapies and things to talk about. So that's been, eye-opening for me, just, relearning, gosh, how common is severe hypoglycemia. One thing that I'll just say is that Steve and I did an analysis of over 30,000 type 1s in the country, looking at their electronic medical records in terms of episodes of severe hypoglycemia, and found that actually as people's A1Cs went up, they became more at risk for severe hypoglycemia. So the teaching has always been, as you drive somebody's A1C down, you can have more severe hypos, which is true. But on the other side, when the A1C is 10, 11, 12, 13, those people are at very high risk also. Maybe because they're just taking insulin intermittently, and then when they take it, it's a big slug and they go low. So the bottom line is there's no A1C that keeps you safe from a severe hypoglycemic episode. So this idea of running people sweet to avoid hypos, it's just not a thing. So what I've learned is that every type 1 needs a prescription of glucagon, every type 2 on insulin. And those are the ones that we forget about probably the most. That we get lulled into this idea that type 2s don't have hypos. And it's less common than type 1, but it's still there. So again, this is what this glucagon resurgence has brought up. I have it in my template now and in all my notes, glucagon. Make sure that I've addressed it. These things now have a 2-year shelf life, which is another good thing, because patients would get them, they would expire, they wouldn't have them, whatever. So it's all good stuff for glucagon.
There is no question that the pre-mixed glucagon is a major advance, as is the nasal. One other group to target for outfitting with the glucagon reserve are those with hypoglycemia unawareness, as well as the 14 to 15% of patients with type 1 diabetes who have the HAF syndrome, hypoglycemia-associated autonomic failure. The syndrome can also be seen in people with long-standing type 2 diabetes, and they are at risk of severe, recurrent, life-threatening hypoglycemia. When we do prescribe glucagon for such people, we actually intend for their loved ones and living companions to use it. So they might be too incapacitated to administer glucagon. So we must not fail to educate spouses and living companions to use and deploy the glucagon kit appropriately.
Yeah, I'm looking forward to mini dose glucagon to treat my lows instead of hot fudge sundae. Dan, before we go to the next topic, do you want to make a comment on all these new glucagon preparations?
No, I think we started out by talking about pramlintide and really buffering insulin and not having unopposed insulin, and whether it's with pramlintide or continuous glucagon or in development somatostatin receptor antagonists, etc. I think we're really going to be able to, prevent hypoglycemia and not just treat hypoglycemia as we have discussed. And I think that's a very important and exciting area of research.
You should be Prime Minister of Canada for sure. Okay.
Glucagon.com.
we have a little bit less than 10 minutes left. So Sam, I know pre-diabetes is one of your interests. It's one of mine as well, being an investigator on the DPP. Give us a few of your thoughts about pre-diabetes.
Well, it's 3 times more prevalent than established diagnosed diabetes, and it is responsive to interventions that will not only prevent progression to diabetes, but reversal of the pre-diabetes status back to pristine glucose regulation. And it is smart medicine to really target pre-diabetic stage and institute interventions, hopefully non-pharmacological interventions, and that also should be cost effective. And it is a kind of intervention that tends to ingrain in the participants, so it tends not to wash out the way metformin or other medications showed a washout effect when we tested them in diabetes prevention programs. So what's not to say for pre-diabetes? It's a question of manpower, focus, and motivation, as well as reimbursement policies by third-party payers to really foster a new culture of targeting and intervening at the level of pre-diabetes.
Yeah, who else has a comment on that? I'm saying that a lot of medications that have been shown to prevent type 2, companies are not interested in marketing at that stage because, many are generic and they can't get the formal indication for pre-diabetes. And I think type 2 is a continuum. The earlier you intervene, the better. Rury, do you got any comments on that, being around diabetes for a couple centuries?
Thank you, and the rest, yeah. So the issue with the hyperglycemia, of course, is it's occult silent and causing damage. So we have diabetic retinopathy and diabetic kidney disease specifically because they're glucose driven. And if you don't have a high glucose, you don't get them. Once they've taken off, of course, other risk factors and things come into play. We discussed that earlier. So intervening at the earliest possible stage will minimize those risks, prevent you moving on to type 2 diabetes for many years. So you're buying time. And when we talk about the legacy effect, people think about that from our UK PDS study and from the DCCT. What that is actually telling us is you can never play catch up. You can't reverse the clock. So finding people at the earliest opportunity, treating them well, keeping their glucose low is a no-brainer. And I think, Sam, I'm entirely on your side. It's just how we do it and how we find those people and then what treatments. Dan may have a view about which treatment. I know he said this before.
Well, I would just remind, we all know as clinicians that one of the hardest things to do is to convince people to take a medication to prevent a problem 5 or 10 or 15 years down the road, whether it's a statin or whether it's a glucose lowering agent. It's often helpful if, sadly, there's someone in the family who developed complications, so the person has firsthand knowledge of what might lie ahead. But these are among the most difficult conversations. I know you feel well now, but I promise you, if you take this medication every day for 10 or 15 years, you will prevent a problem down the road. Just very difficult clinically.
And that is why it's imperative. That's why it's imperative that we approach this through non-pharmacological interventions that make the individual actually feel better, look better, feel healthier, and maintain a habit of healthy life choices. And that was actually more powerful than drugs in the DPP study. Lifestyle change was twice as effective in warding off type 2 diabetes than was metformin.
Yeah, and we're psyched, and we're psyched to see. I didn't mean to interrupt you there, but it seems like you guys have really even started as clinicians giving prescriptions based on food and based on exercise and mindset, all of that. So it's exciting. I was wondering, Jeremy, back on the type 1 front, as thinking about type 1 prevention or delay, can you talk more about immune-based therapies to prevent delay?
Yeah, I mean, what a year for type 1 diabetes. I mean, we truly had a landmark event, and that gets thrown around a lot, this term, but the landmark really happened that we have the first, to be approved preventative therapy for type 1 diabetes, anti-CD3 teplizumab. And I think people have been up to date on the studies, but this is taking at-risk individuals with type 1 diabetes. It's a 14-day IV course of this immunological medication that showed to delay type 1 diabetes by about 2 years. And they recently had the forum or the FDA meeting. And I did the open public testimony. Steve was also involved. And when I was making that speech, I really thought about my different roles in type 1 diabetes as, a researcher, a patient myself, but it came down to the being a father and having 2 kids that are 6 and 3, and would I give them this medication if they developed antibodies? And the ultimate answer is yes. And some of the panelists were saying, well, what is 2 years of delaying type 1 diabetes? Does that really matter? And for me, the difference between a 6-year-old and an 8-year-old, or an 8 and 10, I mean, that's huge in terms of a child's development. In addition to all the advances that can happen in a couple of years, I mean, all that time is extremely valuable. So that is important to get this approved, but it also creates just a new stepping stone, that we have, this new therapy that we can add therapies to. And it starts the conversation again around, gosh, type 1 diabetes is an immune disease. I mean, we kind of forget that. We're so invested in insulin and continuous glucose monitoring and ways of basically dealing with the problem, which is important. But coming back to the root cause of what type 1 diabetes is and ways of potentially preventing it, it's been an interesting conversation that's starting because of this. And I think it's really, really exciting.
Yeah, really, really good comments. Well, okay, we're gonna take a short break now, 15 minutes, so that you can go check out the virtual health fair where you can visit with the companies that are supporting the forum and learn about their drugs, devices, services that they are providing. And when we come back from the break, we'll be talking about some of the exciting developments that occurred at the ADA over the last 4 days. Kelly and I will be asking riveting questions to our panelists, and we'll see you back in 15 minutes. Kelly, do you want to say anything?
And we just want more questions from all of you. Thank you for everything that you're throwing into chat.
Yes.
Thank you to the panelists and Steve.
Hello, everyone. We're waiting a few minutes for Kelly to join us, but before Kelly comes on, I want to make sure I thank all of our sponsors, all of you for joining today. There you are, Kelly. And I also want to say a big shout out to Close Concerns that puts out the closer look that keeps us all updated. And I would say not only especially during COVID times, and we're doing a conference virtually, but also it's something that I think a lot of people can really enjoy and stay up to date, because you just can't go to every meeting at every time. So Kelly, you got on. Thank you.
Everybody,
and
just listen to one last session.
Oh,
Excited to get started. And Steve, I want you to make sure you're going to answer this question too, right? But we have the history of so many just distinguished alum out there who have been presenting as part of our TCOYD and diaTribe forum. We want to ask all of you, and can we start with Davida, and then we're going to go to Sam, and then Jeremy, and then Rury, and then Dan, and then Steve. We want to ask you all, just like, what have you been the most struck by here at ADA Sci Sessions 81? Take 2 minutes, 3 minutes.
Well, technology is my deal. So I'm totally struck by just the comparisons, the availability, what's out on the market, the newer insulins, what's going on with the GLP-1. I just found it a ton. The other thing that I found was great is that there was so much for type 2 diabetes that we don't always see. So I just thought there was great information and great data for everybody with diabetes.
Davida, one thought I had was, it's been type 1 the last couple of years, but man, with the explosion of things coming out in the type 2 field that I'm sure some of you will talk about, I do think now there's exciting things going on in both areas.
That's what I thought. That's one of the things that really struck me, that some of the data for people with type 2 diabetes was just outstanding.
Okay, who's next?
Sam, come on.
All right. So what's not to love about this very convenient virtual sci sessions, which you can take in from the comfort of your home study or your office desk? The challenge was the principle of not being able to be in 2 places at the same time. But the cached sessions allows you to just go back and play. So I've taken in a number of the sessions. I've been impressed by the offering indeed. And the abstracts also are pretty impressive. One particular abstract, if time permits, that I would like to flag would be the audit, the interim audit of how the CDC-propelled National Diabetes Prevention Program is panning out. What sort of numbers are being referred there, and how are they doing, and what are the interim predictive variables as to whether level of education, commercial insured status, Medicare, what kind of background predicts that people would lose weight and prevent diabetes if they've already been recognized as having pre-diabetes.
Okay, thank you.
There's never, ever been so much focus on prevention at this meeting ever, has there? Rury, do you have thoughts on that you want to jump in with? We'll go to you. I know I said Jeremy next, but you've done so much historically on prevention and know so much. What do you think?
Yep, so following on from Sam, there was a really insightful discussion by Herzl Gerstein, setting the scene for prevention, emphasizing the need for environmental change and at a population level. I mean, there were key messages there for healthcare providers, distinguishing between what we do for high-risk individuals who need immediate treatment and what we do for a population that's developing diabetes, type 2 diabetes, so quickly. So we need to pull both of these levers, and I would recommend that talk if you haven't seen it.
Rury, did you have anything else, or
oh yeah,
just
it's an amazing feast, isn't it? And as Sam said, you can dip in and out of everything, and particularly where two sessions are in competition, you can go back and see them. So I thought Jens Holt's Banting lecture on the history of incretins was phenomenal, leading right up, of course, to tirzepatide and this brand new co-agonist looking at GIP and GLP-1, which I'm sure Dan will talk about. But bringing these amazing A1C and weight reductions in a population with relatively recent onset type 2 diabetes. So I think that offers hope for early intervention, as Dan was saying before. I think the other one I would pull out is the Amplitude O study, the pramlintide study, a cardiovascular study of the GLP-1. And I think this just cemented the class. So first of all, this is an extendin-4 based drug, and there had been some concerns that maybe the extendin-4 derivatives were not as good as perhaps the more human analogs. And what they showed was pretty much identical results. It confirmed that it was independent of SGLT2 treatment of base, which is really important. So we're getting additional benefit. It confirmed reduction in heart failure and renal protection. And this was in a population that had an average duration of diabetes of over 15 years. So this is much more end-stage diabetes than the other trials have looked at. So we're beginning to cover the spectrum, and I thought that was very helpful. There are plenty others, but I'll let other people get their say first. I'm sure we'll come back to the other points.
Thank you.
Yeah, my turn, Steve.
Jeremy, go for it.
Okay. So, I guess being the type 1 representative or one of them, there was no real landmark type 1 trial that stood out, but I was happy to see a symposium on type 1 diabetes and cardiovascular disease, which was an interesting symposium. It was mostly kind of reviewing the state of affairs with type 1 and cardiovascular disease. So obviously there's been a paradigm shift in type 2 diabetes in terms of all these medications and improved CVD outcomes. I mean, you can't have a diabetes meeting these days without talking about cardiovascular disease and this whole just kind of new era of clearly glycemic control is important, but other drugs that address cardiovascular disease, renal disease, all those kinds of things. And I'm hoping that this is the next wave with type 1 diabetes, that we have to remind ourselves that even in like well-controlled type 1s that have an A1C less than 7, they're still at a 2 to 4-fold increased risk of cardiovascular disease. So obviously we always need to control blood sugars to prevent microvascular disease, but we're missing something when it comes to cardiovascular disease in type 1s. And this is where I see the role of adjunctive therapies being in type 1. Not necessarily that we need another therapy to improve glucose, although that would be really nice, but can we address insulin resistance? Can we address obesity? And that might be the next thing in terms of improving this important outcome. And in doing so, I would actually like to see this phrase of adjunctive therapy go away, because I think labeling these therapies, adjunctive therapies in type 1s, automatically puts them in this class of like they're frivolous or they're unneeded or they're, you know, over there. But what if we have therapies in type 1 that can improve insulin resistance? All these things that we've been talking about in type 2 for a long time, I think we need to bring them into the type 1 picture a little bit more to improve overall care.
I'd say we junk the adjunctive therapy word.
Yeah, so it doesn't have to be the poor stepchild.
Seconded.
Dan, please.
Well, I don't have that much to add. I think I love the virtual format, but I think we all miss our friends. I miss talking to people, and I think the people who put a lot of work into talks, the majority of sessions didn't have a live Q&A, so chat and Slido is fine. It's not the same as looking at someone's eyes and seeing their emotive expression. To reiterate, Rury, you know, I think the GLP-1 class had a huge win, whether it is higher doses semaglutide or semaglutide for obesity. F-peglinitide was a star today. Tirzepatide is amazing. And even if you want to look at the GRADE study critically, you know, the only drug that looked like it was really nominally reducing CV events was liraglutide, although small events and not all adjudicated. So I think, as Professor Holman said, we really solidified the current status of the GLP-1 class, and huge progress going forward with newer agents that are even more powerful. So that's my myopic Anchorton view of the meeting so far.
Thanks, Steve.
I just wanted to say one thing, everybody. If you haven't been to Insulin 100, the University of Toronto put together so much amazing education on that, and it was really interactive. And I know we also loved all of the Q&A. But back to you, Steve.
Okay, well, gosh, going last is always the toughest because.
Let me just jump in with Kelly, because thanks for that, Kelly. But I think what we all love is these types of discussions. You know, presentations are great. They're a little dry, they're a little didactic. But at Insulin 100, we had 5 or 6 of the faculty at every session talking for 45 minutes about the field. And they're all recorded, they're all up online, it's all free. And almost 8,000 people have taken advantage of that. And it's just there as a resource for the next little while. So feel free to pick and choose among your topics and really hear great live debates from stem cells to time and range to pumps, etc. It's all there.
Dan, give everyone a one-liner of the best website to look for it.
TCOYD, oh no, sorry, insulin100.com.
Okay, that's easy. Thank you. No, I appreciate that. And that's why things like the forum are good, because it's more than just getting up and presenting data. Well, my overall take is that a little bit, obviously some repetition, but it really has been huge for the GLP-1s and SGLT2s. I think the cardio-renal protection data is way more impressive than last year. Then you add on finerenone to the picture, and we could really make an impact on 2 of the most undiagnosed issues in type 2 diabetes is, you know, chronic kidney disease and congestive heart failure. And I think we're going to talk about it in the Q&A that, you know, how do these results confer over to type 1? Because that's what people are talking about. And I really, and to add on to what Davida said, you know, we're now true partners with nephrologists, cardiologists, and primary care doctors with these 2 drugs that show benefits not only in people with type 2 diabetes, those without type 2 diabetes. So we just have to increase our awareness. And for the people that are still seeing patients, you know, that urinary albumin to creatinine ratio and the eGFR, and then the BNP and cardiac ultrasound, we can do a lot more to prevent morbidity and mortality. And then of course, Dan already mentioned the high dose GLP-1. Think about this. Look at the weight loss they saw with the high-dose semaglutide. I mean, it's not just diabetes and microvascular complications. It's obstructive sleep apnea. It's still the best treatment for NASH, despite all the promises of new drugs. It's weight loss, and weight loss, and of course, cardiovascular risk reduction. And I don't think we can say anything more about tirzepatide other than it's just amazing. And we're going to talk about that during the Q&A. And I think we really have to improve we have to work on adherence and persistence, because if people aren't taking the medication regularly over the long term, you lose every benefit. And that's, of course, Dr. Bill Polonsky's area of expertise. With type 1, I'm going to change my name to Stephen Time and Range Edelman. It's all about time and range. I mean, I would say this, it is the standard of care for type 1, like Jeremy said. It's going to be super important and standard of care for many subclasses of type 2s. And what I saw at this meeting was inpatient benefits, pregnancy benefits, ICU, pediatric, adults. It's about time that folks are catching up with the importance and the magnitude of what CGM can do, but you have to engage your patients. And if you don't engage them on looking at the numbers and working with their caregiver to make changes, then once again, you're missing out on the benefits. And of course, this is a year where we're seeing a lot more on totally closed loop bi-hormonal systems, one from Europe, some of the partial data from the United States. So we're getting there. And even though it's not a cure, it's going to bridge the gap until there's a cure. So in my last day, yeah.
Well, I wanted to jump in and say to you, like, what can patients be asking their healthcare professionals, their healthcare providers, if they're just taking what you guys, I think, call monotherapy, is there a reason that they should be thinking about combination therapy? I'd love to hear from all of you also about what you would suggest people with diabetes might ask their healthcare professionals. And we know that you guys all feel so strongly about mindsets that people have: food, exercise, sleep. Adam Brown, the great. But yeah, if you can help us translate for all the people on here, what questions do you guys like to hear?
Well, I'll just add that Kelly encouraged patients to get knowledgeable about the kind of information we're talking about, diaTribe, TCOYD, other sources. And it's a rare caregiver that will tell someone, I don't want to listen to any suggestions, so my suggestion to people with diabetes, take it easy on these doctors with big egos. And if you think there's something that would benefit from that's an area for conversation. Anybody else, please jump in there.
Well, I don't think we can say that most of us don't use monotherapy, but I suspect this group probably doesn't see people at that level of their diabetes. And what I would say is that there is just such remarkable data to be using GLP-1s, especially with people who are at risk for cardiovascular disease. And we don't have to worry about A1Cs. If the A1C is at still goal, we're going to continue to use it. So I agree with you. The patient has to be their own best advocate. And for the patient who may just be on metformin, they're probably in primary care. And that's not bad. Primary care physicians do, and healthcare providers do a really good job. But come in with your suggestions and come in with your ideas. And I think that sometimes, we, in the best of situations, we may forget something. And someone says to me, oh, I'd like to try. Sure, you're a candidate for that. You want to try it. Let's move that forward. But the other thing I would also say is that we need to work on access so that access is consistent for all people. And that we don't have discrepancies based on the type of insurance somebody has or doesn't have, because I think that that's something that has to change in the United States. And so people benefit by that as well.
Yeah, you know what, Davida, though, at DQ&A, they've done a bunch of study on this. Richard Wood, their CEO, said that 40% of 1,000 type 2s that were asked the question about CGM, why they didn't use it, all of those had coverage. And they said that they had never been offered CGM by their doctor or nurse or healthcare team. Does that surprise you?
No, but it goes both ways. I think sometimes we don't offer it, and sometimes there isn't coverage for patients to get what they need. And I'm not talking about CGM. I'm talking about medications. I'm sorry, Steve, take back control.
No. You know what, Kelly? I neglected to introduce Dr. Tricia Santos. Wave your hand, Tricia. You might be on a different section of people's computers. Tricia is an amazing endocrinologist, and she has been given the task to scour all the questions during the first hour and during this session, and we'll be asking questions to the panelists when we get to that point. Kelly, are we at that point? You want to let Tricia go and ask a few questions?
Tricia, thank you.
Sure, I'll start out. I'll say a lot of the questions in the Q&A, there's quite a few questions I think that are very patient-centered and from patients themselves. But kind of something that may apply to both patients and providers. I'm curious after, what you said, Jeremy, about focusing on cardiovascular benefits and these, preventing these other endpoints for people with type 1 diabetes. How do you all feel about the data that we have so far, and can we apply that already to patients with type 1? Some of these studies that we've had already in terms of cardiovascular benefits, heart failure, renal benefits, have been shown to be beneficial in patients without diabetes at all. And is that good enough for you to say, maybe we should think about the risk benefit in patients with type 1? And are you using it for that reason?
Let me take a crack at that. So I've been thinking about that a lot, and I'm torn between two paths. One is to pedantically demand that studies be conducted with appropriate follow-up in the relevant population, namely type 1 diabetes, that meet the inclusion criteria for the renal status or cardiovascular status as type 2 before I would act. However, some of the studies you referenced, for instance, the DAPA-CKD or the DAPA-HF and similar other drugs, enrolled nearly half of the cohort without a history of type 2 diabetes and showed equivalent benefits in terms of kidney protection and reduction in heart failure events. So if we accept that an individual with type 1 diabetes does not have type 2 diabetes, then he or she would belong to the non-type 2 diabetes segment of the population in whom benefits were demonstrated, unless you want to convince me that type 1 diabetes in and of itself independently buckles any trend and negates any expectations of SGLT2 or GLP-1 array benefits. So if we need to translate immediately what we already know, I would look for people with the EGFR brackets, 25 to 75, that were enrolled, people with a history of New York Heart Association stages 2 to 4 heart failure with reduced ejection fraction, less than 40. And if they have type 1 diabetes, I would still consider them potentially beneficiaries of those organ protective strategies, pending the relevant studies being planned, conducted, and completed.
Dan, Jeremy?
Yeah.
Please.
So I think.
So Sam, you're entirely right. So you do need some studies. So people with type 1 diabetes are not the same as people without any diabetes. And the risks, for DKA and things are at a different level. So if you were to prescribe these routinely in primary care practice, you may run into some problems. So I agree with you, it's an enormous opportunity, but we should just tread a little carefully before we roll it out as a routine. And exactly, we need the studies, and the potential for people with type 1 diabetes is enormous. I think if we can show that, then we could roll it out much more quickly.
Okay, Jeremy, you go, and then Dan will after that.
I agree with everything that was said, but at the end of the day, it comes down to you have that patient with type 1 diabetes that's in your clinic and their GFR is 45. I mean, am I going to pull the trigger and prescribe an off-label medication in this, patient that may be at higher risk with CKD? I mean, I honestly believe it would be a benefit, but it's just without the data, it puts you, you're just kind of out there on your own. Do I prescribe it or not? So I would love to see, more studies come to light. These are approved in Europe, other places to get that data, because I don't see a reason why it wouldn't benefit people with type 1 diabetes. And it would be a huge boon to start using these as, again, getting rid of this adjunctive term. And we're just using this as a therapy, just like we do in type 2, to help reduce outcomes of interest, heart disease and CKD. So that's all I'll say.
Agree.
I think the data for SGLT2 inhibitors is much more compelling when thinking about the type 1 population than the GLP-1 receptor agonists. There we really have a paucity of data. And, medicine is imperfect. We all make decisions often when we do not have randomized controlled clinical trials. In fact, 90% of the things we do in clinical medicine are not evidence-based. And so, we've said this before, but it's all about the risk benefit. And if you can mitigate the risk of ketoacidosis, which is real with any insulin-sparing therapy, and in particular, some of the SGLT2I mechanism might contribute a little bit more to that, then, it's going to be 5 to 10 years till we get the perfect data that informs this. And I personally would not wait. If I had someone with type 1 diabetes who was knowledgeable about watching for ketones, and they said, Doc, I'm worried about my eGFR, I'm worried about my heart, what do you think about the SGLT2 inhibitors? I think that would be a safe thing to do in terms of probably a good thing that I would predict in 5 to 10 years would be supported by the evidence. But I would respect anyone else who would say, well, I've calculated the number of new episodes of ketoacidosis and hospitalizations for ketoacidosis just to replay the FDA advisory committees. So it's an individual decision, but I would never criticize anybody on either side of that decision.
Can I just say that, I think that if the SGLT2 inhibitors were up for approval in type 1 diabetes today, they would be approved. I think at the time that they went through, the FDA meetings, we were all there for sotagliflozin, and it was 8 yes, 8 no. It was literally down to the wire if they were to get approved or not. And just in the current climate, if that, same kind of, class of agents came to the FDA, I think there is this undercurrent of belief that that these have other benefits, that we've already mentioned, that it would have a better chance of getting approved. So it was just about the timing of, when they went through.
I'll say it a different way, Jeremy. I think if these drugs came to the renal division of the FDA, they would have a very good chance of being approved. The diabetes division has been a little bit more uneven with sotagliflozin, with ITCA 650, and obviously now we're all talking about aducanumab and Alzheimer's disease, et cetera. So today's FDA is a bit more unpredictable in a number of ways.
I might say it, Dan, a different way again. Dr. Lisa Yanoff, man, she is watching out for every single one of us patients out there. And so, I buy it. Like, you guys are also watching continuous ketone monitoring be developed and all of that, right? There's a lot of good technology, I think, that can come.
Yeah, Bruce Perkins, where I work, has been very eloquent in saying there are risks every time we introduce new technology, whether it's, pumps or SGLT2 inhibitors, et cetera, but we can educate around and mitigate those risks and potentially capture those benefits. And so I think most of us would probably not deny, off-label use of an SGLT2 inhibitor in a knowledgeable, careful person living with type 1 diabetes. That's my guess.
And I think you described the kind of person that you would give it to, so that we didn't add to the risk of DKA or add to the publication of DKA.
Tricia, I'm sorry.
I just want to say one last thing that's interesting is that I mentioned in the opening thing that I was part of this ADA EASD consensus guidelines, and my role was on the adjunctive therapy side. And so it was, half people from the US representing ADA and half people from, the EU. And when it came to SGLT2s and type 1s, more of the ADA people were in favor of using them, off label than the EU people of using them kind of on label and like where it's actually approved. So there was this real kind of disagreement about what our recommendations should be around this medication. And it ultimately came down to, just as you said, Dan, careful patient consideration, and as long as people are ketone monitoring and these kinds of things, and left it as we don't know what to say about cardiovascular and chronic kidney disease. And that's kind of all the recommendations we could give.
Hey, Jeremy, do you think you'll end up seeing real world evidence on it for type 1s who are taking it off label? Or do you think there will be any more data that you guys will be really watching? Or what kind of trial would you like to see created?
Yeah, the real world data on that's going to be tough. Finding these patients, following them for years and looking at, CVD outcomes. So hopefully we'll see more kind of like short term, maybe mechanistic studies to just try to keep this effort going. But ultimately it's going to take the big CVOT type study to definitively show that. I don't see that happening anytime soon.
When statins were first launched and demonstrated to be powerful in decreasing MIs and cardiovascular disease, does anybody recall whether separate type 1 and type 2 data sets needed to be demonstrated? Or did we accept at face value that LDL reduction by such powerful agents would benefit any and all individuals at risk?
I don't think there was any separate data sets initially.
I don't recall either.
No.
So there was the ISIS trial, which was run out of the Oxford group, not my group, had about 700 patients with type 1 diabetes, and their hazard ratios were pretty much identical. So although they didn't set out to ask that question, it was great confirmatory evidence.
Right, and they did the 4S, the subgroup for diabetes, and found similar pattern of response. So that was reassuring.
Yeah, but I think one of and Roar's the trialist here and other people as well, but the benefit of SGLT2 inhibitors is so rapid that the trial does not have to be this monstrous lifetime achievement. It has to be properly powered, but I think the effect size and the time to benefit is really in the favor of taking this on for type 1 diabetes if there was a willing sponsor.
Yeah, good point, Dan. Well, Tricia, give us the next question.
Yeah, kind of a general question. A lot of people are excited about the GLP-1 data coming out, and many of you mentioned the tirzepatide. I'm curious just go into a little bit more detail about what your thoughts are and how this is going to change your practice, if and when it's approved, and how do you weigh this against the data that we now have with high dose semaglutide?
I say let Dan go first. He's Mr. GLP-1.
And we won't have to say anything.
Yeah, so I think this is going to be fascinating, and we've already talked briefly about access to medicines and payers and reimbursement, because that's going to be an obstacle. It's very difficult for a payer of a large country to think about tens of millions of people going on an expensive once weekly GLP-1 drug as the first therapy relative to a much less expensive therapy. But as the patient living with the disease, knowing that if I was going to go on tirzepatide, I might lose, 15% of my body weight and have a normalization of my hemoglobin A1C. Unlike any other first option for type 2 diabetes, it would be very hard to justify other than for expense. So, we don't have the perfect comparative studies, but these results are unlike anything we've ever seen before with tirzepatide. And I think, even 2.4 milligrams of semaglutide is now going to be very impressive in terms of the marketplace and real world data. And we're going to see more combinations, as we've talked about, with cagrilintide and semaglutide and other combinations. So I think that we're in a transition. And the way I always look at this, and I know it's silly, is I always think, well, wait in 10 years when tirzepatide is generic. And then hopefully the price will be much lower and the access will be much greater, because I think there's so many people that would benefit from the weight loss and the fantastic glucose control. And I'm guessing that the CV benefit is in the bags, because I personally believe tirzepatide really functions as a very good GLP-1 receptor agonist with a little bit of GIP thrown in intellectually. But I'd be interested to hear what other people have to say. I think it's going to, I hate to use the word game changer. I dislike that word, but I think it's unlike anything we've ever seen before.
So, Dan, if I could come back to you, that I think it is a potential game changer. I think also it might have an easier regulatory pathway. So this is a single molecule co-agonist, and we have an example of that with Entresto, the saxabutyl valsartan molecule that Novartis brought in for heart failure. They had a big struggle getting that through because the fixed ratio effect sort of was not standard for the regulators. So I think there is a smoother pathway. But the question I was going to ask you, it's been used in relatively early diabetes, where beta cell function is still pretty good. And so the GIP effect, I'm not quite sure the extent to which it needs that beta cell function. And as you go further down the pathway, you may or may not see the same benefit. So the current data is fantastic for early diabetes. I agree. If this was cheap as chips, you could give it to everybody. But do you think it will have the staying power, or will we have to add other treatments going down the line?
Yeah, so I'll preview my Tuesday morning ADA overview of tirzepatide. I am not convinced that the GIP moiety is adding a lot. For some of the reasons that you mentioned, the weight loss, I think, is almost all GLP-1. I don't want to get basic sciencey for too long, but if you give this molecule to a mouse that has no GLP-1 receptors, there's no weight loss. So I think the GLP-1 component is what's driving the success of this. And there will be others who disagree with me, and I'm sure GIP does something in terms of insulin sensitivity, but I think it's just a really good GLP-1 receptor agonist that when it hits that GLP-1 receptor, because of the conformation, it's doing stuff that we have not seen before with the other molecules we have available.
And with regard to the cardiovascular benefits, I haven't seen the data yet, and I think we might have to wait till 2024. There is a study ongoing with an active comparator, tirzepatide compared with dulaglutide, and that speaks volumes for the confidence of the manufacturer. Either they are going for non-inferiority to dulaglutide, which had previously demonstrated cardiovascular superiority over placebo, or they're actually wagering that they would beat dulaglutide in the cardiovascular game. Either way, it would be reassuring that there is cardiovascular benefit in addition to the profound metabolic benefits that we have seen.
So across the SURPASS program, and the sponsor has already disclosed this, summarizing all of the MACE together gives a hazard ratio of around 0.8. So again, that's not a CVOT, but I think it's very reassuring, and it's consistent with this just being a really good GLP-1 receptor agonist.
Right. However, we would still need to see the data because, Dan, you'll recall the DPP-4 inhibitors before the studies were reported used surrogate inferences and gave us very optimistic projections about cardiovascular benefits, even referencing cardiac extrapancreatic receptors doing wonderful things. But when all of the gliptins were tested, they were safe, but not necessarily superior to placebo. So,
yeah, I accept your point. I'm just very confident that this is a GLP-1 receptor agonist and will perform as expected. But I accept your point that we need the CVOT.
With regard to expectation that price would come dramatically down with generic transition, say a decade hence, I'm not too optimistic because I think what pharma has been doing is not abandon the generic transition to some Indian generic company, but they keep a foothold and manage the process such that on average, the price gain to the end consumer has been around 15–20% decrease from the branded price, which is a shame really, because one would have expected that generic transition would bring the price way down and provide access to far more people. But at least for some of the insulins and other
Yeah, you're absolutely right. Anyone who is familiar with the insulin story would 100% agree with you. But I think that hopefully we have a new administration in power in Washington now. They hopefully might be more sensitive to these access issues, and maybe we will start to see a a tide turning. But you are right that the maneuvers that are available to the pharmaceutical companies unfortunately prevent the more rapid decline in pricing.
Yeah,
well, I didn't invest, but these are investments, not costs, the studies. And NIH has jumped in so much over the years. So maybe that can happen next. I hope so. What do you think?
Not sure what your question is, Kelly.
Oh, well, DCCT, I mean, that was NIH investing in it. And can NIH invest in the right studies for the underprivileged, underserved, even for a lot of the type 1 stuff that you're asking about?
I will tell you, I'm from Detroit, and we really get pushed when we get research study, whether it be NIH, pharmaceutical, it doesn't matter. We are asked to be very sensitive to making sure that we have very diverse group in our in who we recruit, and we go out of our way when we're looking at like the biopancreas study. We were asked to do 50% non-white, and we almost got there with the numbers that we recruited. And I think that you have to make a concerted effort, especially more in almost in type 1 than in type 2, to be able to see that. And you can't just say, I'm going to keep randomizing, because that's easy to do. But we absolutely make a concerted effort to make sure that we're culturally diverse, so that when we have the outcome, that we can make those generalizations to all people.
I would just add that I think one of the silver linings of COVID is that we're more aware of inequity, of diabetes drugs to individuals hit hard by type 2 and type 1 for that matter. And I have heard from my Lilly and Novo colleagues that they are going to really put some effort into access, opening access, keeping the price down, low for seniors, et cetera. So I do think I think it's going to be a little better, and I'm just keep my fingers crossed.
Yeah, I was just going to say, Steve, all that they got combination GLP-1 and basal into the senior savings plan. Maybe not everybody knows that, but you guys want cultural competence to be taught in medical schools, nursing schools, all of that, like math, is in all throughout the schools. So I know you guys can make a big push. You have so much influence, and you too, Tricia. We would love to hear what you have to say about this.
I find it interesting too, though, that for formulary purposes, that insurance companies have jumped on the bandwagon more with SGLT2 inhibitors and GLP-1s, and not putting roadblocks up with PAs and very high copays. Now, people still have deductibles. We still have, people go through donor house. There's still a lot of issues we have to deal with, but it's almost that the insurance companies get the added benefit in terms of cardiovascular benefit and renal protection. And I have truly put up less barriers to access. We just need to move those forward.
Yeah, even the Veteran Affairs Medical Center has opened access. Well, we have time for one more question. Tricia, would you like to choose that?
Sure, I'll keep it broad. Albert Kai wrote this question, which I think is kind of fun way to end, which is, what is your bold prediction for the most exciting talk from ADA 2026? And I'll just say, always kind of looking to the future, there were lots of comments on things like, where are we going with implantable sensors? Or when are we going to have, fully closed loop available? Or what's happening with encapsulated beta cells? And we didn't touch on these kind of longer acting once weekly insulins. I'm throwing a lot of topics out there all at once, but do you see any of these as kind of rising to the top in the next several years, or what do you predict is going to be the next big thing?
Stem cells and islets, and I think when you talked about exciting, so I think smart insulins are exciting, but even more exciting is cell-based therapy for type 1 diabetes, and I think there's going to be a huge momentum now. We can engineer the immune system, I think, cleverly with CRISPR-Cas. We're getting better at making differentiated cells. There are multiple companies and academic partnerships underway, and I think this is really what I look to as being the excitement of the future, and not just incremental, but really transformative innovation in 4 years.
So in type 2 diabetes, just to change the paradigm, I think the big change here is the GLP-1s and the fact that we've now have oral preparations with new preparations coming along from other companies. And the idea that we can use these in low or even high dose in pre-diabetes or early diabetes, I think is a game changer. Having to start an injection early was always a barrier. But now we can get a really powerful drug, no risk of hypoglycemia, weight loss, cardioprotection. I mean, what's not to like? I think as these certainly come off patent, Sam, then we will see these used much more widely. And I would hope in that time frame, we'll see that become a standard of care.
Well, Rury, you mentioned earlier it may be a game changer. Then you mentioned 2 other times after that it is a game changer. For a Brit, that's pretty impressive.
I think technology is going to blow us out of the water. I think all the things you said, 100%, I agree. There's just so much that's going to be beneficial to people with diabetes, but technology is just leaps and bounds in terms of the quality of sensors, the usability of insulin pumps, the fact that people don't have to worry about their highs and their lows, and pumps will do that for them. I just think that technology is mind-blowing. It continues. And the fact that we're working on changing, getting rid of the C-peptide and, getting rid of 4 finger sticks to get CGM and all of those things. But I'm just so impressed with how much technology we have to offer people with diabetes that we can count on. And it's good technology. I mean, when the first CGM came to the market, we all knew it was about 25%, 30% off. We didn't care because we were so excited about getting it. And now we have technology that's not only good, but it's super accurate. So that's one of the things I loved.
Yeah, I'll just follow on that because I agree. And I think in the type 1 space, these artificial pancreas type technologies, I mean, glucose control in type 1 diabetes is a solvable problem. And, we're almost there in terms of getting, fully automated artificial pancreas, but everybody talks about the artificial pancreas like it's one thing, and all of a sudden it's going to be there one day and we're all going to celebrate it. But obviously there's going to be iterations, and it's going to get better and better and better. And so 5 years from now, there will be technology available. It's another question of who has access to it and who wants to use it and things like that. But there will be technology available that will automate insulin delivery, and people with type 1 diabetes will, for the most part, have reasonable glycemic control. And I think, again, to my previous point, that will help usher in this next generation of, okay, we've got glycemic control, at least we're working on that, adding to other therapies for long-standing type 1s, to address these other issues I talked about with cardiovascular disease. So I think that'll be really helpful. And then to Dan's point, I do think the cellular therapy is going to continue advancing. These things take time. I've been involved. We did the first ViaCyte implant here 7 years ago. And, just released at the ADA now, getting, glucose responsive, insulin production from these cells. So it takes time, but when you can generate beta cells, from stem cells, that's a big deal. And now we're left with, how do you package these? How do you, alter the immune system to make them kind of take hold? But we're already to the point where we can generate beta cells from stem cells, and that's a big deal. So I think another 5 years from now, we will hopefully have made significant strides in how to implant these and how to get these, and a scalable issue into how to get these to the masses.
Sam.
Well, I think that in addition to technology and CRISPR and life-changing discoveries, there is a mundane, low-hanging fruit that I believe health planners would take advantage of. End-stage kidney disease in America is an entitlement. You do not need to be insured. Once your kidneys are gone, the federal government becomes your daddy, picks up the cost of dialysis, which currently is about 3 sessions a week to be kept alive, each session costing $1,000 to $1,500, $4,000 a week, 50 weeks, $200,000 a year. And for a fraction of that, you can have early exposure to SGLT2 inhibitor in your earliest departure from normal kidney function, and delay the time to dialysis, maybe even over several years or decades. Healthcare planners and payers will do the math and find that providing access to SGLT2 inhibitors early in the pre-terminal stage of kidney dysfunction makes big sense economically and societally. And so in 2026 sessions, somebody may be showing us graphs indicating plummeting of the current statistics, whereby 50% of all dialysis centers are inhabited by people with diabetes. And now if you add the non-diabetic kidney disease bundle together, you can see how much the graph could plummet if people are given upfront protection. So I'm hoping that kind of approach would also be included in the future trajectory of caring for our patients, particularly with kidney disease.
Yeah, thank you, Sam. Well, Tricia, you said 2026, but Jeremy and I made a video approximately 2 years ago on type 1 diabetes in 2026. I was working at Starbucks and he was cutting hair because the university let us go. They didn't need us anymore, thanks to all the technology. So hopefully that still becomes true. And I should just say in closing and let Kelly get the final comments is that I want to thank all of you so much for your time. And I want to thank all of our sponsors again for supporting both our organizations. Thank everyone online, and we will go through all the questions and try to answer every one of them, because I know we didn't have a chance to. Tricia, thank you for being helpful and our kind of question moderator. And Kelly, thank you so much for all that you do for diabetes. Please, you can say the final thanks or whatever you'd like to say.
Oh, Steve, right back to you. Well, I love getting to be in community with this incredibly distinguished panel. And again, our huge appreciation to all of the organizations who are helping make it happen out there. And I know that there's so many ideas coming through the chat that they will really appreciate as well, all of our sponsors. I also just so appreciated all of the patient centricity that Jeremy gets everybody to think about all the time. So do you, Steve. And, so we just say all the patients out there who are asking about more focus, and we want more focus, but we want more studies, you guys, and we want more published studies. Like that is how we change much more on access and adherence and engagement. And in the great words of the Stanford scholar, the behavioral guru, BJ Fogg, these guys, you want to help patients do what they want to do, and you want to make everybody feel successful. And I'm looking at all of you and you are making it happen. Thank you so much to everyone at ADA as well for making a really extraordinary conference.
Well, thank you, Kelly. And remind everyone watching that the health fair is open for at least another half an hour. So go visit. They're serving free champagne at, no, they're not.
Really cool. You bring your own.
That's what I miss about the real face-to-face meetings. Oh my God. Well, we're going to get some June shine at the TCOYD office. And I guess that's it. We want to thank everyone. And I'll see you in the TCOYD booth.
It's great. Everyone at TCOYD, your team, Steve, did such an amazing job pulling this off. Thank you to everybody.
Thank you.
Team as well.
Thank you so much. It was fun. Take care.
All righty.
Bye-bye.